Hi class, welcome to your first of two lectures on the respiratory system. So this content comes from chapter 17. We also will cover chapter 18, which is on the movement of the respiratory gases throughout our body. But they're both shorter chapters, so putting them together shouldn't make it too much longer than what we typically do in a week's time. All right. So in this right now, in this lecture, we're going to focus on the respiratory system and then on ventilation. We will cover gas laws, but that's going to be brought into chapter 18. So don't worry about it until we get to there. So when we think about the functions of the respiratory system, sure, we think about breathing, but let's also just highlight some of the other functions associated or that are dependent upon the respiratory system. Goodness, I always do that. Sorry about that. So yes, we do have the exchange of the respiratory gases between the atmosphere and our blood, so gas exchange. The respiratory system is also very important in the regulation of our blood pH. And changes in our breathing patterns can lead to changes in the blood pH. So we do have compensatory mechanisms through our respiration that are tied to blood pH. The respiratory system has important functions in protecting us against things that could cause an infection or allergens or other irritating factors. For example, the lower respiratory tract has cilia in them, and the cilia beat up in a upward and outward motion. And that helps to expel material that enters our lower respiratory tract. That is an example of a physical barrier of the immune system, but it sits within the respiratory system. And then also the ability to make sound is tied to the respiratory system. So these are the four main functions of the respiratory system. Now, movement through our respiratory system is dependent upon bulk flow. And that we've seen this before. We talked about it we've actually talked about it in a few of our chapters. The circulatory system uses bulk flow. And this is just simply movement of materials down a concentration gradient. So the diffusion of molecular oxygen and carbon dioxide following their concentration gradients. That is what propels or sets up the opportunity for the movement and distribution of our respiratory gases. We're going to learn too that pressure is really important in that as well. We did learn that in our cardiovascular system, right? We learned about how flow is dependent upon the change in pressure over the resistive forces. We're going to visit that again here. So the bulk flow does carry material, respiratory gases in this example, following that gradient, high to low. And we have a pump that is important in helping to create pressure gradients in our body. We're also going to learn about the importance of the difference between the atmospheric pressure and what is in our body, because that's a very significant difference. So that does also contribute to this bulk flow movement along gradients. And we do know that anytime, again, we're talking about flow, that the sum of those resistive forces or the consequences of those resistive forces can oppose it. There's an inverse relationship between resistance and flow. So if the airways narrow, that will increase resistance by decreasing the diameter and that would consequently increase the pressure right there. Okay, so in chapter 4 of the textbook, that's when we learned about cellular respiration. That is tied here since we need oxygen for respiration, but it's not the topic of this chapter. I'm going to pause the video for one moment because my cat is just outside the door. Excuse me. Okay, sorry about that. He's back in safe and sound. All right, so here we're talking about what is properly called external respiration. And it is tied to the different areas of exchange of the respiratory gases. So we have a level of exchange between the atmosphere and the lungs. And the cycle of ventilation includes the inspiration, breathing in, as well as expiration, breathing out. So the reason I listed it this way on your slide is because these are not separate things. Ventilation, it would be incorrect to just describe it as inspiration. It's not. It is the full cycle of inspiration and expiration. So once the oxygen, molecular oxygen, has entered into the lungs, then we have exchange between the airways and the blood vessels. And that's for both molecular oxygen and carbon dioxide. And then, of course, those respiratory gases are transported through the blood, where they then get to our third level of exchange, which is between the blood or the cells that are in the blood, moving out into the tissues where they can exchange with the cells. So we have 3 layers of exchange or levels of exchange in our respiratory system. So let's see that here. So we've got the incoming of molecular oxygen. So this is exchange level 1, which is between the atmosphere to the lungs. And we're specifically talking about the alveoli of the lungs. These are the small airways where respiratory gas exchange occurs. So equivalent to the capillaries in the cardiovascular system. Exchange level 2 is from the lung to the blood. So we're seeing the movement of molecular oxygen out of the alveoli sacs through the different barriers between these structures, right? We've got the endothelial layer of the alveolar sac, as well as the endothelial layer of the blood vessel. And then in it comes and it's pumped around the body through the help of the heart. And that brings us to our third level of exchange, which is between the blood itself and the cells. So those are the levels of external respiration, of which there are 3. And then we can also work it going backwards, just in opposite orientation. And the backwards pathway, or I shouldn't say backwards, completing the circuit, here we would be looking at a different gradient. It would be the gradient of carbon dioxide, which is going to be highest in the tissues, in the cells that are using it for cellular respiration. So we generate the source, if you will, of carbon dioxide, which is the product of cellular respiration, giving us a gradient that facilitates the diffusion of it back into the blood vessels so that it can continue its pathway out of the body, where it is eventually expelled as carbon dioxide in the typical gaseous form that we think of. So those are the 3 levels of exchange. Sometimes you see them broken into 4 steps because we've got the transport of those respiratory gases through the body. In fact, I originally had the previous slide here organized that way, with this being step 3, but I clarified it to hopefully make it a little bit more simpler so that it does align with these exchange levels. All right, so let's just go over the essential anatomy that we need to so that we can understand how our respiratory system works. Well, similar to in our cardiovascular system, we have a network of airways that are different sizes, and they have different components that make them. Some of the airways have muscle around them, and that ties to their function. But before we get into that, oh, sorry, when I got my cat from outside, I got cat fur all over my nose. We've got our upper respiratory tract versus the lower respiratory tract. And basically the lower tract is from the trachea down. So it involves the lungs themselves and the airways that are associated with the lungs. By far, there are way more infections in the upper respiratory tract of a person compared to the lower tract. Part of the job of the upper respiratory tract is to protect this lower respiratory tract, the lungs, from any type of infectious or physical insult. So the airways are commonly referred to as the conducting system. Now, the sites of exchange are the alveoli, and these are the smallest diameter. Well, let me think about how they're actually a sac. They go into a bubble, but they're the smallest of the airways in terms of the structural components that make them. And then we've got our thoracic cage, and that includes the skeleton that's in there, as well as the other organs and connective tissue. And this might not be as inherently obvious, but we need our thoracic cage in order to keep the lungs and airways in a physical state so that they work. You could even just try this yourself. If you bundle yourself down in a tight ball, it's hard to get a good deep breath. So the anatomy helps to create the right structure so that our airways are utilized to their maximum efficiency. So this would include the bones and muscles of the thorax that are all around the lung. It includes the rib cage, the spine, the diaphragm muscle, which sits below our airways. And then we've got a number of other groups of muscles that are tied to the respiratory system: the intercostal muscles, the scalenes, the sternocleidomastoids mastoids. And then finally, we get the pleural sacs also. And there are two. Each of our lungs sit within a sac. And then there's fluid in between the two layers of the sac and the pleural membrane itself. And in that fluid, you can think of it like a lubricant. It's normally slippery, but it helps to, it's essential to allow the lungs to fit tightly into the thoracic cavity so that the airways can expand and contract properly. Okay, so we've got, here's the cutoff at the level of the trachea between the upper respiratory system and the lower respiratory system. So the upper system would also include the ears, the nose, all of the sinuses, for example, the vocal cords. And then from the trachea down, it branches into the right and the left bronchi, which then branch into progressively smaller airways, just like a tree, or just like we learned about in our cardiovascular system. Now, the left lung and the right lung are a bit different. They are divided into what are called lobes, L-O-B-E-S. The right lung has 3 lobes in it, where the left lung has 2. And you can see that over here, maybe a bit easier. So we've got 1, 2, and 3 lobes in the right lung, and just 2 in the left lung. And then we can see the cardiac notch carved nicely so that it fits and wraps the heart. So everything fits very nice and snugly in the thoracic cavity, which is part of what is needed to create and maintain the correct pressure dynamics that allow for bulk flow to happen. We can see back over here in the left side of the figure, the diaphragm, which sits underneath both of the lungs. So we'll learn about how the diaphragm moves, how it contracts and relaxes, and how that is tied to the act of breathing. Oh, let me point out that the trachea has quite a lot of connective tissue wrapped around it. That's what these little blue rings are. And that's true of some of the airways. So just like we learned about with our blood vessels, different airways have different materials around them or in them, and that's tied to their function. I mean, the trachea and the bronchi need to stay open. If they close off, there's a major, major problem with everything below it. So they've got that more rigid structure to keep them open, to provide, if you will, an exoskeleton around those airways. All right, so let's focus on part C of this figure. On the left here, I want to just point out the relevant muscles, not so that you, this is an anatomy, again, you've heard me say that before, but in order to understand how our thoracic cavity works and how the anatomy supports the act of breathing, we really need to look at the orientation of these different muscle groups. So we're on the left side of the figure, which would be the right lung. We're looking at what is highlighted here. These are the muscles of inspiration. And then we have on the right side of the figure, the muscles of expiration. So of course we have both sets on both sides. This is just the way the figure is, so that it can hopefully help to clearly identify which muscle groups are associated with which action. So our muscles of inspiration, it does include the action of the diaphragm, and then the external intercostals, which run kind of downward in an angle through our thoracic cavity. It does include the sternocleidoid mastoids that run in the neck. And actually an indication that a person is having respiratory distress is that you see these muscles working harder than they should. So that's often one of the signs that a triage nurse or paramedic looks for when they are assessing a person for shortness of breath, or how hard it is for that person to breathe. I mean, a person can maintain an oxygen level but still have to work very, very hard to do that. So that's just one of the physical clues that can indicate a person's using too much effort to breathe, is when we see these muscles active in the neck. On the for the muscles of expiration, it is the internal intercostals for expiration, as well as different sets of the abdominal muscles. So this includes the oblique muscles and some other sets as well. So the diaphragm is something that is associated with inspiration, and hopefully you'll begin to understand why in just a moment. Now, if we take and cut a person horizontally, that is looking at what's called the transverse section. So we're literally looking down on an image of the thoracic cavity being, cut at about here. So we've got the right lung, we've got the left lung. You can see some of the bigger blood vessels and lymph vessels that are present in the lung. But look how nicely tucked in the thoracic cavity is. We can appreciate it, I think, from this view. So the heart is nestled in between the lungs. Even the big vessels of the heart help to anchor everything in the thoracic cavity. We've got the aorta. Here's the esophagus, which is opened up when we eat. It's closed off normally so that we can breathe. And then what I really want to point out in this view, though, is the pleural cavity. So this is the area in this kind of dark slate gray color. So we've got the endothelial layer of the lung, a cavity, and then we've got the endothelial layer of the membrane of that pleural sac that each lung sits in. So in between it, there is a space, which is where the pleural fluid is, and this should be nice and slippery. These two surfaces should not rub. They should slide by each other. In fact, when they start to rub or that fluid dries up, that is a condition called a pleural effusion, where we get a buildup of inflammation, including the inflammatory cells in that cavity. So that's not a good thing. We never want to have that because it can impact a person's ability to breathe. And in some cases, when there's a buildup of fluid in the pleural cavity, it can become so significant, so large, that it can collapse the lung. I actually had that happen when I first moved to Tucson to go to graduate school. There is a common mold there called coccidioides mycosis. It causes a condition called valley fever. And I got it. I didn't know I had it. Oh gosh, it was actually this time of year in 1997, because I was hospitalized. I was hospitalized through the Thanksgiving holiday. But within a matter of 2 to 3 hours, I started out feeling fine. And then my temperature went up very quickly to about 103. I was achy everywhere. And by the time I got to the hospital, my left lung had partially collapsed because there was such a buildup of infection from this fungal mold infection. And it was right in my pleural cavity. So fortunately, the fluid went away on its own. I didn't have to have it drained. My body worked properly in that regard. So there should not be inflammation there. The whole purpose of that fluid is as a lubricant to prevent any rubbing or sticking of the lungs together against the pericardium. Wrong sac there, against the pleural sac. The pericardium is the sac that holds the heart. It's kind of similar though in structure and function. You can see the pericardial cavity around the heart here. Okay, so looking at the branching from the trachea down through the left primary bronchus to the secondary, down to the bronchioles, and finally to the air sacs, the alveoli. So bronchial has this ending we've seen before. We saw it when we studied arterioles. That ending is not a coincidence. These are the airways that are wrapped with smooth muscle that can apply resistance to increase pressure. So that's similar to our cardiovascular system. So we're showing a very simplified view here. This primary bronchus divides 22 more times. We're just looking at one branch. So it's very extensive. And then down at the bottom are the alveoli, and they look like a bunch of grapes. So let's zoom in to this box, and that's what we're seeing over here. So first of all, here's one of the sacs shown empty and hollowed out. So you can see that there is a lot of membrane here. It's that same, one of those same core themes in biology we've talked about all semester, where we see an increase in surface area to volume ratio. Here it is in this example. So this just simply provides more area, surface area, for the exchange of the respiratory gases. If it's only a small amount of area, it would slow the process down. And then looking over towards the right side of the figure, you can begin to appreciate how extensive the vascular system is here, which makes sense. What would be the point of having an extensive alveoli branching sac mechanism if we didn't have the blood vessels to pick it up so that that exchange can happen? Because in the lungs, we're at that exchange level 2 between the lungs and the bloodstream. So therefore, we need the bloodstream to do that. So we've got very extensive capillary beds that surround each of those alveoli bulbs. There are lymphatic vessels here, just like we've seen in other parts of our body. They're present here, and they serve the same function. They help to recover fluid and also move some of the fatty molecules through there. Now let's take a look at all this muscle, that surrounds the bronchiole. So here's that ending, I-O-L-E, just like we saw on arterial. It is the airway here that is wrapped with smooth muscle that is under the control of our sympathetic and parasympathetic responses. Let's see, I think that's all I really wanted to emphasize here. Oh, and then we can see here's the pleural cavity shown at the very bottom. Okay, so zooming in a little bit more, we're looking at the alveolar sacs. So I'm trying to outline one of those sacs, and you can see that there are many cells that make up each sac, right? We need to have the epithelial tissue to actually make up the sac. So we've got 1, 2, 3, 4 different sacs, or mainly shown here. We can see bits of others. There's a lot of blood vessels, which are needed. But then we also have these type 2 alveolar cells. These are the ones that secrete surfactant, which helps in the lubrication of the airways. So we've got type 1 alveolar cells that do gas exchange, and then type 2 are the ones that produce surfactant. Now, on the topic of surfactant, part of a risk for a premature baby is that they may not have produced their own surfactant yet, depending upon on how far the pregnancy went through. So nowadays, premature babies are given surfactant, and it really has helped to reduce many of the ill health effects and deaths that were associated with premature births. We do have dedicated immune system cells in the airway. So this is a macrophage, which is constantly just doing that process of phagocytosis. Macrophages are able to do antigen presentation, so they can initiate the adaptive immune response. And we do have specialized macrophages that live in the lungs. All right, so now let's look at kind of the sandwich of the layers involved if something were moving from the bloodstream or air sac to the bloodstream. So up top, we're looking at the blood vessel. So we've got a red blood cell in there. We've got the endothelial layer of the blood vessel. And then of course, the fluid matrix, the plasma. Then we've got a section in gray here. This is the basement membrane. I think of it like a subfloor, if you will. That might sound weird, but we have basement membranes below all of our exchange surfaces, and they help in creating the structures necessary to make the anatomy. In this case, it's fused, so it's attaching the different epithelial layers. So the purple here is the epithelial layer of the alveolar bulb or sac, and then below it in that lighter blue color is the surfactant, and then we get the alveolar space. So the top part is the capillary, the bottom part is the alveolus. And then we have movement of gas exchange going both directions at this level of exchange. This is exchange level 2 in the respiratory system, going between the lung, specifically the alveoli, and the blood. So if we're thinking about oxygen moving, that's, right, we've got quite a few surfaces that it goes through. So having a strong concentration gradient as well as pressure behind it helps to facilitate the timely movement of gases through our respiratory system. Okay, so just looking at the branching, I'm not going to ask you questions about how many there are on this side of it. I mean, to me, that's just not really a useful detail. That's just memorization. I more want you to be able to understand that we have different types of airways that are made of different materials and they serve different functions. So we have this same core theme of structure and function coming up repeatedly. Please do know the division and the diameter of each of the types of airways. So alveoli, for example, are divided 24 times. That's just in one lung. And their average diameter is 0.3 millimeters, where the trachea has an average diameter of 15 to 22, depending upon the age and size of the person. Our bronchioles, so we can divide our bronchioles into two categories, but they're the same structure. But we have bronchioles that are on the conducting system, so that and then we have so that is within the airways, and then we've got bronchioles that are associated with the exchange surfaces as well. But we do have quite a bit of division in there, and their diameter is slightly bigger than what we see with the alveoli themselves. So we have the bigger vessels going into smaller vessels, but then there's way more of these smaller structures. I shouldn't call them vessels. They're properly called airways, or the conducting exchange system. All right, so type 1, gas exchange again. Type 2, produce that necessary surfactant. There is also connective tissue, specifically elastin and collagen are associated with our airways. The alveoli are wrapped with the capillaries, as we saw in that picture. And if we want to talk about the direction of movement of say, molecular oxygen, it's following the gradient of high pressure to low pressure. So let me back up a moment. When we're talking about gradients, yes, there is a gradient of the gas itself, That's true, there is. But we're talking really about the gradient associated with the pressure change. So we're talking about a gradient of high pressure to low pressure. The pressure outside in the atmosphere is higher than anywhere in our body. But as we move to the alveolar sacs, that's where the lowest pressure is, so that the material slows down enough to facilitate exchange, since that is the job of the alveoli. Kind of like what we learned about with capillaries in the cardiovascular system. So the pathway is, will begin in the right ventricle, since we're talking about the pathway of gas exchange. So that would pump blood to the pulmonary trunk, to the pulmonary arteries, into the lungs, into the veins, and then to the left atrium. And then an assumption is that the blood flow in the lungs is equal to the blood flow in the rest of the body, meaning that the exchange is highly efficient, that whatever oxygen is in the blood, in the lungs, let me say that again. Whatever oxygen is present within the blood vessels in the lungs, it is going to get to the rest of the body. And that's been supported with plenty of scientific data. Okay, so taking a look at one of the submucosal glands and how it associates with the respiratory trunk, and also the cilia are located here. We can see them more on the right side. So there are a number of submucosal glands on our respiratory system that produce mucus and other materials, but we do have a direction in that the respiratory pumps and the cilia keep material moving up and out of the lower system. That's part of the job of these structures, is to protect the lungs, to protect the exchange sites from any damage, so that oxygen and gas exchange is not impacted. So we've got a combination of mucus being secreted, as well as there's other glands that secrete saline, just so that we have a lot of fluid. When a person is breathing hard and heavy, it's easy to dehydrate. And so what I'm using this for is just an example to show or tell you that we do need a good amount of fluid movement to have proper respiratory function. All right, so now we're going to zoom in just on actually part of the epithelial layer here. So we've got two areas. So behind it, sorry, I lost my mouse. Where'd it go? That's bizarre. My mouse just disappeared. Okay, well, I'll have to use my trackpad. So here we've got our basement membrane in blue, and then we've got other connective tissue behind it. And then the cilia are at the very ends of these epithelial cells. So all of the purple are the epithelial cells of this lining, and then they extensively branch, increasing the surface area to volume ratio. There's my mouse back, at where the cilia. So the cilia are able to move in the fluid, the mucus, the saline, as well as with the action of the muscles to keep material moving up and out. So this is how we get dust out, even how we get some infectious materials out of our airways. The goblet cell here in yellow, these are the type of cells that produce mucus, and they're called that commonly in our body. Goblet cells are mucus producers. All right, so we're going to get to gas laws in the content of the next chapter. So now I'm going to move to ventilation, which includes both inspiration and expiration. So that is what one respiratory cycle is. Now we have different volumes in our lungs, and they change at different parts during a ventilation cycle or respiratory cycle. So first of all, we need to define what these different volumes are. And the lab is helpful at help in allowing us to understand this. So we have volumes, and then we have capacities. So let's go just through what each of these are. And we can measure these on what is called a spirometer. And commonly, these are a group of tests called pulmonary function tests. We do this on the BioPack machine in lab, but we also have the PhysioX activities that I'll demonstrate in lab for you. Okay, so we have 4 volumes. And then a capacity is a combination of 2 or more volumes. So, so sorry for all the words, but I want you to know what they are. We have our tidal volume, and that's the total volume of air that moves in the respiratory cycle. We have the inspiratory reserve volume, as well as the expiratory reserve volumes. So the inspiratory reserve volume is the additional space after tidal volume. So for example, I'll try to just demonstrate. So I'll breathe a normal, I'll do 3 normal respiratory cycles. Okay, so I did 3 tidal volumes, but then I went into my inspiratory reserve volume when I took the big deep breath in, because I pulled more air in. But then I had my expiratory reserve volume, which is the amount of air that has to be pushed out after normal respiration. And then that brings us to the residual volume, which is an amount of air that basically just stays in our respiratory system, trapped in our respiratory system after we do a maximum exhalation. So those are the lung volumes. And when a person is being worked up for something like asthma or COPD, this is part of the diagnostic procedure. Now, capacities are the combination, the sum of volumes. So the vital capacity includes the 2 reserve volumes, inspiratory reserve volume, expiratory reserve volume, plus the tidal volume. So it is everything other than the residual volume, where our total lung capacity is all 4 volumes. And we'll talk about our inspiratory capacity and our functional reserve capacities as we progress through this chapter and the next, but also through lab. Okay, so pulmonary function tests are done by a technician typically, and that does this, that is their job. That's what they do. They administer these tests. And the way that we do it in lab is quite a bit different from how it's done for a clinical purpose. I've had these tests done since I have asthma, and you actually sit in what looks like a phone booth, like the kind they have in England, but it's a plastic box and it's completely sealed off. And you breathe into a tube, but that way they can figure out how much air is moving because they know how much air is in that total box, and they can control the settings and the volume. So as what a spirometer does, this is looking at what's called a wet spirometer, which we do this in the lab, but this is not typically what's done for clinical purposes. But we'll begin with this. So the way it works is there's like a tub of water that has a bell in it. And this bell is connected to the tube that the person pushes air through. So it fills with air and then it rises. So, and then it's connected, it's connected to a chart recorder, just something to graph the changes. And so as the bell moves up, when the person blows air into it, when they exhale, we see a movement in the graphing part of it. So here's inspiration. So we're increasing our volume, followed by expiration. So this is one respiratory cycle. And then we have a second respiratory cycle followed behind. So the volume of the bell decreases, and then the chart recorder will start to trace it. So that is the wet spirometry, and it creates a closed system because this bell is sitting in a tub of water. So the air that's exhaled from the person goes right into the bell, and then they can breathe it back in and out and in and out. It's not escaping to the atmosphere or into the water. All right, so this is a graph of a pulmonary function test, but it shows pretty much all of the volumes and the different capacities. So there's a lot here. Let me try to walk you through it because yeah, it's difficult to know what all this means. So first of all, we're going to begin by looking at just the 4 lung volumes. So we have our residual volume, we have our expiratory reserve, we have our tidal volume, and then our inspiratory reserve. So it shows you the relative volume occupied by each of these spaces. So our inspiratory reserve is way bigger than the residual volume. The tidal volume is bigger than the expiratory reserve volume, is a way to look at it. So I'm so sorry. So let's bump down to the graph. So our inspiratory reserve volume for males is quite a bit higher, 3,000 milliliters versus 1,900 for females. And just to look at the 2 we pointed out up top, our tidal volume for males is 500, and for females it's about 500. But then our expiratory reserve is 1,100 versus 700. So it's difficult to appreciate the respective volumes looking at just this figure. It's more just showing you that there's 4 of them. You really have to come down here and look at them to appreciate the different sizes or the volumes occupied by them. Okay, so now let's move to the tracing from the spirometer. So what's happening first is the person's told just to do normal breaths, just normal breathing. So I'm going to go through the pattern of breathing for each of these movements in the graph, and then we'll come back and talk about what they are. So this is inspiration, normal, expiration, inspiration, normal, expiration. Now the person's blowing out as hard as they can. They're blowing as much out for as long as they can. So they're trying to expel everything in their airway. So that takes them down to the lowest part, to what is the residual volume. This part doesn't ever move out within the course of this test. And now they're going back up. So we've got our expiratory reserve volume. Okay. And then we go back into our normal breathing. And now the person does a big deep breath in. So we get our inspiratory reserve. which begins at the top of the tidal volume. A common mistake is students will say the inspiratory volume includes the total lung capacity, but it doesn't. It doesn't. It's not doing this normal tidal volume breathing, I should say. So it starts here and then it goes up. And now the person's been told to blow out everything they can and make that breath last as long as they can. So they're like blowing like this. It's like blowing the biggest birthday candle out you can imagine. And a good respiratory therapist is going to be encouraging the person to keep blowing, keep blowing, keep blowing. So that gives us our vital capacity, the whole thing here, when we go all the way down to the bottom of the expiratory reserve. And then they breathe back in and go into their normal tidal volume, their normal respiratory cycle. Okay, so the green part is the residual volume, and a person can train over months to years through endurance training, and they could use some of that volume, but it's not going to change in the time course of when a person is having that test administered. So notice that the total lung capacity does include all the volumes, but the vital capacity does not include this residual volume. Okay, so capacities are the sums of two or more volumes. So one of the ways that this test is done incorrectly is to do it too quickly. So if we were doing this in the lab ourselves on the BioPack machine, where we can do it on BioPack, I would actually have you do about 10 normal breaths first, so that you're more in the cycle of that tidal volume prior to doing any of these other assessments. I've learned to do it that way. It gives much better results. And I know some of the other faculty have now started to do it that way too, because it leads to more accurate results. So this is the pulmonary function test, and they're done as part of the diagnosis of somebody that has a suspected respiratory disease. But they can also be done periodically to see if it's changed. Another way that they're useful is to see if a person responds to a certain medication, such as a bronchodilator. So a bronchodilator is something that immediately opens up the airways. It's an inhaler. So you can incorporate the use of the inhaler into this machine, this testing, and see sometimes that the volumes increase. Okay, so now let's go back to kind of where we started and talk about the thoracic cavity and look at how the diaphragm fills the space and allows us to breathe. So first of all, we're going to go through the three images of the chest on the left side. So we're beginning at rest and the diaphragm is relaxed. So when it's relaxed, it's in the upward bell shape. And notice how it fits nice and tight up against the lungs. Now, please appreciate the lungs have a dotted line that we can see in part B. So this just shows us that we have now, in inspiration, the lungs have expanded. They've moved out, and the diaphragm has flattened through contraction. So our thoracic volume is increasing. So our lungs expand, but also the diaphragm flattens down, it contracts, which allows the lungs to take up more space in the thoracic cavity. And then we go back to how we started with in expiration. So now the diaphragm relaxes and goes back into the bell shape. And then our lungs go back to the shape at which they started at rest. So that is how the diaphragm works. So when we're at rest, the diaphragm is in its relaxed position. The right side is just showing a slightly different way to appreciate the movement in the thoracic cavity. So this is like one of those, like a well a person might have in their backyard. It's similar to the kind of pump that's on it, a pump handle. And what it's showing is that the motion of the pump handle, which you would push down and it goes back up, and you push it down and it goes back up, it's simulating the movement from anterior to posterior, so front to back, that's happening in the rib cage. So the handle is representing the movement of the sternum and the ribs, which kind of do this kind of movement as our lungs expand and then come back. They expand and come back. So that's what it's showing us, is that the rib, I mean, it's kind of tricky to appreciate, but it's showing that it's moving, not necessarily down, but it moves the orientation of the rib. And then from the front view, this is looking at the side. If we're looking at the front view, it's like a handle on a bucket being moved up or down. So we can see the sternum in the center. So that's the very center of the rib cage, where everything wraps back. And we've got, and so it's going up, kind of up and out as the lungs expand during inspiration. All right, so pressure gradients are what's all tied into the movement of our respiratory gases from the atmosphere all the way to our cells. And like we learned back in the beginning of the semester, the change in or flow is equal to the change in pressure divided by the resistive forces. So when we breathe in, there is an increase. When we breathe in, okay, let me back up a moment. We have different areas of pressure in our lungs though, right? There's a pressure in the sac, in the alveolar sac, but then we could also think of the pressure, say, in the pleural space in between the two, the lung and the sac. So when we breathe in, the alveolar pressure decreases because it's pushing the air out to the blood. So at time zero, the pressures are equal. And if the pressures are equal, there's no change in pressure, which means there's no flow. But a little bit within about 2 seconds is when the inspiration happens. And then expiration is longer. So it's usually over seconds 2 to 4. And it's associated with an increase in pressure, which pulls the molecular oxygen from the atmosphere back into the body. So we have the pressure that pushes the material to the next level of exchange, but it's almost like it creates a back pressure that then helps to bring more respiratory gas in for the next cycle. And that's what we're seeing here. Okay, so we've got our lung, we've got our diaphragm, which is in its relaxed position. So now let's identify our different pressures. So the red line is the pressure in the alveolar sacs. And then the blue line is the pressure in that cavity. So that's called the intrapleural pressure. But as the lungs expand, there's going to be pushing of the lungs against the pleural sac. And then we have the volume of air moved. So let's begin down at the bottom where we just look at the volume of air being moved. So it increases to about 500 milliliters and then drops back off. Increases, drops back off. So notice the shape of the curve is a little bit different on the inspiration than it is on the expiration. It's sharper on the expiration. So it's not necessarily longer on the expiration. I mistakenly said that a moment ago. It's there's a different arc to it, but it ties to these two pressures. So alveolar pressure decreases with inspiration and then increases at expiration. And then it decreases with inspiration and increases again. The interpleural pressure, now look at it, we've got a different dynamic between the alveolar and the interpleural pressure. So our interpleural pressure decreases and then it increases with expiration, decreases with inspiration, increases with expiration. So the overall direction is the same between the alveoli and the interpleural pressure, but look at the difference in the slope of the curve. So our interpleural pressure goes back up quicker than we see with the alveolar pressure. And that has to do partly with the amount of volume that's present in each of these areas too. So our pressure does change during breathing. So normally our expiration, I don't know. I mean, it does take a little bit longer than inspiration, but we're not able to plot it accurately with following the pressure here. Okay. Now let's apply the change in pressure actually to a clinical scenario so that we can help to understand the role of the thoracic cavity and these pressure gradients in the exchange of respiratory gases. So we're looking at what's called a pneumothorax, and this is a medical emergency. You know, somebody would need to get probably to a trauma center pretty quickly here to deal with this. What shouldn't happen is pulling out the knife, because once this knife goes in, it could be plugging up a hole, but once it's removed, then you have a gaping hole which would lose pressure. So let's look at the lung at rest. So we've got our pleural cavity shown in between these two blue lines here, pushed right up against the rib cage, right? And then we've got the diaphragm in its relaxed position since we are at rest. So what we're looking at is this concept of elastic recoil of the chest. And what elastance mean, it doesn't mean stretch. That's not what elastance is. Elastance is after you've stretched, it's going back to your normal position. So after we do a inspiration and expiration, right? After we do inspiration, we've got to do expiration and get back to homeostasis, preferably before the next cycle moves on. So our interpleural pressure is here. We're looking at it at subatmospheric. It's below zero. It's -3 millimeters of mercury. But this pleural fluid helps to keep the lung stuck and adhered to the chest wall. So it's necessary. What happens in a pneumothorax is we've lost the integrity of that seal now, and there's a direct opening to the atmosphere. So the lungs, look, they're not staying anchored into the cavity anymore. The lung is collapsing because of the buildup of pressure outside of it. And hopefully one of the big risks with a pneumothorax, other than it could lead to a person not being able to breathe, when the lung is in this collapsed state, it can damage it. Even if the lung is re-expanded, that could affect the ability of that tissue to work properly in the future. So a good way to demonstrate this, let me just pause for just a moment and I'll be back with an example to help show you how this works. Okay, here I am back again. So this is to simulate the lung and the sac around it. So one side of the plastic bag is the epithelial layer of the lung. The fluid in between is the pleural fluid. And then the other side of the bag is the pleural sac itself. and I showed you this before, but let's go through it again. So all I've done is I took a Ziploc bag and I put water in it, but then I pushed the rest of the air out, and that's really important. But where the water, I mean, it's hard to pull it completely apart because that water is helping those two surfaces to stick together. Notice that the part of the bag, let me try to show you clearer. So look above where there's no water. It's harder to pull it. It stays stuck even though I'm pulling it apart. So I'm trying to demonstrate to you that the fluid, as well as the pressure of that pleural cavity being subatmospheric, is partly what makes it so that the sac and the lung move properly by themselves, but it also helps to anchor everything in the thoracic cavity as well. Oh, there's Meatball. Okay, so if I were to take a knife and pop it, right, the fluid would come out, but then I'd also lose the pressure dynamic inside too. So part of why when I got that lung infection I was telling you about with the fungal infection, I built up so much fluid inside my lung. There wasn't a hole, but I had so much fluid and cells and gunk building up in the space that it collapsed my lung partially. So a pneumothorax means there is air in the thorax. That's what it means, just to give you the technical term. Okay, so compliance is the ability to stretch, where elastance is recoil. So elastic recoil. So we can have what high compliance means is that it stretches easy. So like a loose piece of elastic would stretch easy. Low compliance means it takes more force to do it. So imagine you have a TheraBand, and one of them is, they have different grade TheraBands. Some of them are harder to pull than others. So you have like the least resistance TheraBand, you can stretch it. But then you get the high resistance one, and it takes much more energy and force to stretch it. So low compliance is associated with a collection of lung diseases that fall into the category as being called restrictive lung diseases. This means fibrosis. Fibrosis is restricting. Link them together. Asthma is not in this category. COPD is not in this category. Low compliance is associated with the development of restricted diseases, which means fibrosis. So once the lungs fibrose, that's a scar. That means there's no air exchange happening there. So restrictive diseases are not diseases we really want to be treating after the fact. They are diseases that we want to try to prevent and manage prior to the development of fibrosis. So these can be develop when surfactants aren't there. So premature babies were if they don't have surfactant, which they all do in the United States, they were at risk of developing restrictive lung diseases, where their tissue just does not stretch. And if it doesn't stretch, then they can't expand their airways. So again, elastance is the ability to go back to our normal state after the stretching is gone. So surfactants are work because they break up the cohesive forces of water. So if I added surfactant in it, we could imagine that the water would not be as sticky. That's cohesive, and well, cohesion and adhesion mean that molecules stick together. So that's partly how they work. So these are oil lipid paste materials. They're phospholipids actually, and other small proteins. And we see more of them in the smaller airways, which ties to their increased surface area of the small airways, but also to the function of facilitating gas exchange. So again, premature babies this is not nearly as much of a problem anymore because babies are given surfactant. And in a mother that is at risk of developing or delivering early for whatever reason, depending upon how early that delivery is, sometimes the mother can be given a dose of steroids, and that will trigger the release of surfactant in the baby's lungs. So that's one way to deal with that problem. Okay, so some of the factors that affect airway resistance. So these are the same things we learned about in the cardiovascular system. So the length of the system. However, it's not quite, it's constant here. We've got the viscosity of the air. So for example, living in a humid environment versus a more dry environment, it can be more challenging to breathe in those humid environments because of the water pressure. We've got the diameter of the airways. So obstructions of the upper airway or constriction of the lower airways. So that would be the bronchioles, since they are the airway that have muscle wrapped around them. Those are the airways that can constrict under command and relax. So they are under the parasympathetic nerve stimulation. And then we've also got bronchodilation of the bronchioles in response to a high CO2 combination. So that way the body is signaling to try to get that CO2 out of the body, but also epinephrine through engagement of the beta-2 receptors can lead to bronchodilation. So our diameter is similar to what we learned in our cardiovascular system, where the wider airways have less resistance. So to constrict, clamping down the bronchioles is a way to increase resistance, and that would be parasympathetic response. And then the opposite, bronchodilation, would decrease resistance, and that is under the sympathetic response using the beta-2 receptors muscles that are present on the smooth muscle of the airway. So try to think about just what happens normally, but then maybe take one of the example we learned earlier in the semester and think about what happens during allergy, a severe allergy, such as a bee sting and a person that is allergic, and what happens when they are given epinephrine. So try to think about the process of what's happening naturally during that fight and flight response in the person, but then also what happens when they are given exogenous epinephrine in an EpiPen, because what that's going to do is largely it shunts all the blood to the vital organs so that the person is able to be more aware of their surroundings. So our breathing rate and how deep or shallow we breathe is tied to how well we breathe. So our total pulmonary ventilation is just the amount moved in and out in a minute. And we look at the ventilation rate and the tidal volume. But our dead space is a factor as well in determining the efficiency of breathing. So endurance training, like marathon or triathlon training, is a way that a person can start to use more of that, more of the unoccupied space, or even of that, of the oh my gosh, the reserve volume. Sorry, I couldn't think of the right word there. So our ventilation rate times the tidal volume minus the dead space is a accurate way to look at the ventilation across the alveolar sacs. Okay. So we've got several factors that are tied to how effective our body is at gas exchange, just simply tied to how fast we're breathing or how deep we're breathing. So some of the terms and patterns that we see associated with ventilation, you've probably heard of hyperventilation. And this is when we're breathing too fast, or the volume is changing. So we have an increase in the rate or the volume, but it's not being stimulated by metabolism. Okay. Metabolism or exercise is different. That would stimulate us to breathe faster too. Where a hypoventilation is when it's decreased. So shallow breathing, asthma, even the different restrictive lung diseases are associated with hypoventilation. You've heard of apnea, which is when breathing stops. And that can be done, right? Obviously, we can do it ourselves if we want to, but there's also forms that are associated with the control mechanisms in the brain that are not voluntary control. So hypnepia is the increased rate in response to metabolism. Okay, so these two terms are different. Okay, hyperventilation is when there is no increased metabolism. So hypernemia, I can't ever pronounce that word. This is normal. This is homeostasis. This is the body increasing the respiratory rate after exercise or increased metabolism to get more oxygen in there and to get that carbon dioxide out. Okay, so some of the normal parameters. So this is for an adult. So the total pulmonary ventilation is about 6 liters per minute, where through the alveoli, it would be 4.2 liters per minute. And the average respiratory rate is anywhere from 12 to 20 breaths per minute. So it does have quite a range. Children have a higher respiratory rate than do adults. So the amount of oxygen that comes into the alveoli sacs is equal to the amount that moves into the blood, because it is an efficient process due to the bulk flow and pressure gradients. So, but if we want to look at the fresh air, which would be things other than oxygen, it's about 10% of the total lung volume after at the end of the inspiration. So there is a balance between ventilation and the blood flow rate associated with picking up the respiratory gases. And that just ensures that we have maximum gas delivery between the alveoli and the capillaries that wrap around them. Okay, so we're looking at a graph here of normal ventilation. Or of ventilation, I should say. On the x-axis is the alveolar ventilation, which is increasing in liters per minute. And then on the y-axis is the alveolar partial pressure gas in millimeters per mercury. And then this dotted line represents the normal ventilation rate for the average adult at 4.2 liters per minute. So anything below it would be hypoventilation. Above it is hyper. So what it is showing us is that as our alveoli pressure increases, we do get an increase in the pressure of oxygen and a decrease in the pressure of carbon dioxide as alveolar ventilation increases. So that's what we're seeing here. So in hyperventilation, we're getting an increase in the partial pressure of oxygen with a decrease in carbon dioxide. So it's switching, it's opposite of what's happening in hypoventilation. Okay, so obstructive lung disease would include asthma, chronic obstructive pulmonary disease, COPD, but also the obstructive sleep apneas are in this category. And they're associated with an increase in airway resistance, but they do not result in fibrosis. Our restrictive lung diseases are the fibrotic conditions. And it is possible for a person to have both, but they are different underlying physiologies. So obstructive lung diseases are associated with resistance. So in asthma, part of why it's a double whammy is asthmatics produce an excess of mucus. So that's going to increase resistance. But then also they go into bronchospasms where the bronchioles clamp down when they shouldn't. So that also increases resistance. So by giving them a bronchodilator, that allows for the airway to decrease the resistance. Where restrictive diseases are about reduced compliance. We use a value called the FEV1, which is the forced expiratory volume in 1 minute. So you have to literally blow on that thing for a minute. It's hard, especially if you have asthma. It's really hard to do that. So it takes that number and divides it by the forced vital capacity. But we use this ratio to effectively differentiate between obstructive versus restrictive disease. So if it's 80% or above, that's normal. But if it's less than about 80%, it indicates there's restrictive disease. Okay, let's talk about why. In obstructive disease, there is a change in the FEV1, but there's also a change in the FVC. So because the change is in both the numerator and the denominator in obstructive disease, we don't get a change. It's proportional. But in restrictive disease, it's different. In restrictive disease, we're seeing we end up with a lowering of this ratio. So it depends on which lab or which tests are being used, but generally it's a cutoff at about 75 or 80%. So a decreased FEV1 FVC ratio indicates restrictive disease. It does not indicate obstructive disease. It's actually, this ratio is not telling us anything about obstructive disease because it cancels each other out since both the numerator and the denominator change proportionally in obstructive disease. So there are other values in the pulmonary function tests that are certainly used to assess obstructive disease, but the ratio is helpful in predicting restrictive disease. All right, that is it for chapter 17. I hope to get this back super quick so I can get it to you super quick. And I'm going to move on now to chapter 18, which talks about gas exchange. I hope everybody's doing well, that your families are doing happy, safe, and please stay, keep in mind that the numbers of COVID here are increasing. So it's time to keep up our guard. Take care, everybody. Bye-bye.